Um, Hi, everyone. I'm Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation. And I'm really excited today about our speaker for our new episode of Kidney Cancer Conversations. Dr. Vania Phuoc is here to talk to us about the basics of basic labs. Dr. Phuoc is an assistant member at the Moffitt Cancer Center of Medical Oncology. And she's here today to talk to us about the basics of basic labs. So if you guys have questions throughout any part of this presentation, please type them into the chat box or hold them until the question and answer session at the end. We want to make sure that we get through all of your questions, but we're going to get through the presentation first. So thank you, Dr. Phuoc, for your time today. How are you?
Oh, good. Thank you. Thank you, Scott, for the intro. Let me just share my screen here and we'll get this presentation going.
There we go. We can see your screen.
Okay, great. All right, I'm just as Scott mentioned, I'm Vania Phuoc. I'm one of the hematology oncology physicians at Moffitt Cancer Center. My personal clinical focuses are benign and malignant hematology, meaning both cancer and non-cancer related blood disorders, as well as breast cancers. But I come across patients with every single type of cancer for many different reasons, including blood-related reasons. And I've always had a passion for patient education, so I was more than happy when asked to give this talk on what exactly basic labs means for patients, since it's a very common thing that we encounter in our everyday practice and that patients like yourselves encounter on a day-to-day basis as well. So this is likely a very familiar experience for many of you in the picture. You go in for a doctor's appointment or to your local Quest or LabCorp or lab service provider, and you have a number of different blood tests drawn. I often hear many times that patients have no idea what is being tested or why it's being tested. Then if you have access to your online patient portals, you'll often see reports that look a lot like this, where they list a ton of different lab results, and you can see all of these tests that are flagged as quote unquote abnormal. Patients then naturally become anxious, wondering if there's something horribly wrong with them, especially in the world of cancer. Well, I'm here to help you stay calm, take a deep breath, and learn more about the most common tests that physicians order to hopefully help you feel less anxious and have a better understanding the next time you see any of your own lab results. Today, I'll go over what exactly basic labs typically mean for providers, and I'll go through systematically by organ system what each lab is looking at. Since we only have so much time for this talk, I'll focus on more detailed explanations of the most common labs we order and what abnormal results may potentially mean for those specific tests. And then I'll go over a few example patient cases that I've personally seen where screening labs or quote unquote basic labs really did make a difference for their case. So to start off, what exactly are basic labs? You've probably heard your physician or providers say, we'll get some basic labs and we'll let you know the results once they're back, or they'll add the caveat, we'll only call if they're abnormal. Then you go get your blood drawn, and I don't know how many times I've heard patients say, I had a lot of blood drawn by this provider, but never heard of any results. I just assumed they were normal because they said they'd call if it was abnormal. Well, basic labs are really a way for providers to quickly screen for any really major issues. And what labs are ordered by a provider depends really on their clinical specialties. A primary care provider who's more focused on preventive health screening or managing chronic health conditions like hypertension or diabetes will order very different screening labs than, say, an oncologist or a hematologist. Each lab also may use different testing techniques or assays or machines that have their own specific normal reference range, and anything even slightly outside of this reference range is flagged as abnormal, whether or not it's actually of significance. Starting with the most common basic labs that we typically get, A basic metabolic panel, or BMP, focuses really on the kidney function and the electrolytes related to the kidneys. So it includes things like sodium, potassium, glucose, calcium, also particularly blood urea nitrogen, or BUN, and also creatinine. And they can use this blood test to calculate an estimated glomerular filtration rate, or eGFR calculation. And that helps to give an estimate on your specific kidney function. Then there's the complete metabolic panel, or CMP, where it essentially includes everything that's on the BMP and also liver function tests. There is also a separate hepatic function panel that only has liver function tests itself, but the CMP includes both kidney and liver tests. The liver tests being liver enzymes that we call transaminases, like ALT and AST. And then it also has some gallbladder and biliary or bile duct type numbers, including bilirubin and alkaline phosphatase, as well as some protein numbers, including total protein and albumin. Then the other most common basic lab that we get is a complete blood count, usually with a differential, and it's my personal favorite. So this looks at different types of blood cells circulating in your body, including white blood cells, red blood cells, and platelets, and it gives different descriptors as to the characteristics of the blood counts, including how the red blood cells actually look, and also the types of white blood cells that we see circulating in your blood. Abnormal blood counts can be related, of course, to many different blood disorders, but also many different bodily processes, including chronic kidney issues or chronic liver diseases, etc. I'll go into greater detail about all the different blood count findings that we can see and their meaning later. There's not really enough time to go over in detail all of these other additional common screening tests, usually more commonly checked with primary care providers, but other common basic screening labs that people get include thyroid function tests, cholesterol levels, hemoglobin A1C to screen for diabetes, vitamin D levels. We often screen in adults HIV and hepatitis B and C, and also different cancer screening tests. Most commonly for prostate cancer screening, there's a blood test called PSA. Now, to get to the real meat of the topic, though, what do all of these basic labs really mean? Since, of course, this is the Judy Nicholson Kidney Cancer Foundation, I thought the labs for kidney function would really be the best place to start. So whenever providers talk about kidney function tests, the main ones that they typically focus on or zone in on are the creatinine and the blood urea nitrogen, or BUN. BUN and creatinine are essentially byproducts of normal metabolism that should usually pass through the body and eventually exit the body into the urine in a normal amount if your kidneys are functioning normally. In a similar manner, the kidneys also help to manage your body's levels of things like sodium, potassium, how much fluid you retain or get rid of, etc. So if your kidneys aren't functioning well, then different things that should normally pass through into the urine will start to build up. So you might see things like a high BUN, high creatinine, high potassium levels. Because of abnormal regulation of these electrolytes, we may see that your blood gets more acidic. We may see fluid buildup and thus lower sodium levels because your sodium levels get dilute. So a lot of different things that we can tell just from this BMP and also related to your kidney function. With creatinine, it's typically the most emphasized single kidney function test in clinical practice. And I briefly mentioned earlier the term glomerular filtration rate, or GFR, which really measures how well are your kidneys functioning and filtering your blood as they should be. And the way that we calculate a GFR, or estimated GFR, based on your BMP or your CMP, we take into consideration your creatinine level, gender, age, and race. And if we see that you have an abnormal creatinine or elevated creatinine, we always like to ask a few basic questions to get better sense of the background, as in how long has it been elevated for, because it's very different if your creatinine has been elevated for many years versus if you just had a blood check 2 weeks ago and it was normal and now it's newly high. Also, are there any risk factors for you to have a high creatinine? For example, did you just have a new medication medication started or new chemotherapy started, or do you have long-term high blood pressure or diabetes that can sometimes contribute to chronic kidney disease? And of course, we always want to know, are you making a normal amount of urine? Because it's a very different picture if you suddenly stop making urine, of course, or if you're still making what seems like a normal amount of urine, or if there's any changes in the type of urine that you're seeing. Here it lists out the stages of chronic kidney disease as it goes from essentially normal to very mild, moderate, and then more advanced chronic kidney disease based on the GFR, which helps us to estimate how much percentage of kidney function you have. And then you can see it progress through the stages from 1 to 5 as you get to more advanced chronic kidney disease. For acute kidney injury, this refers to a new insult or injury to your kidneys. And this can show up as a new rise in your creatinine or BUN, along with other changes that we can see with your electrolytes, as well as potentially how much urine you're making. Common causes of acute kidney injury include dehydration or different medications. We always worry about if chemotherapy or immunotherapy used in many different cancer treatments may be potentially affecting the kidney. If you suddenly stop making urine, we always get concerned, is there obstruction or blockage of your urinary system that can cause acute kidney injury? More chronic issues, if you have really high or low blood pressure, that can cause issues with blood flow to your kidney, and that can also lead to a lack of oxygen delivery to your kidney or injury. There's also a staging criteria that we look at to see how severe is this new kidney injury. And it takes into consideration how much your creatinine has changed compared to your normal baseline, as well as any changes in how much urine you're making too. Now, a low creatinine is usually not as much of a concern clinically compared to if you have a newly elevated or high creatinine. So if we see a slightly low creatinine, it's typically not concerning and can often be related to things like getting older, having lower muscle mass, poor nutrition, and many other common things like that. Now for potassium, after BUN and creatinine, potassium is one of the most closely monitored electrolytes in people with abnormal kidney function. Normal potassium is typically around 3.6 to 5.2, and abnormal kidney function can cause potassium levels to go abnormally high because it's no longer filtered normally by your kidneys. When you have high potassium, that condition is called hyperkalemia. Common causes of high potassium include high blood sugar levels. If your blood is quite acidic, different medications can cause potassium to go high. If you have advanced chronic kidney disease and have new kidney injury, that can also cause the potassium to go high. Symptoms that can happen when your potassium goes too high, things like weakness, you can have abnormal heart rhythm changes, and it can be potentially life-threatening, especially if you have severe or significant hyperkalemia. On the opposite end, if you have low potassium, that's called hypokalemia. Common causes, again, medications, especially things like diuretics. If you're on chronic diuretics like Lasix for blood pressure or for your heart, it can often cause loss of potassium in your urine. If you're experiencing things like vomiting, diarrhea, or not eating well, that can also cause low potassium levels. And also if you have low magnesium levels, magnesium works together with potassium. So you can have low potassium because of low magnesium as well. Symptoms of low potassium include, again, weakness, abnormal heart rhythms, muscle cramping, and tissue breakdown. Treatment of potassium levels, whether they're high or low, really depends on the cause and the severity. The next most focused electrolyte, aside from the ones I mentioned already, are sodium. Sodium and water are, of course, also regulated by your kidneys and frequently talked about. Normal sodium levels are about 135 to 145. High sodium is referred to as hypernatremia. So common causes include dehydration. So if you have really low amount of water in your body, that concentrates the sodium levels and causes it to go high. If you're losing a lot of water for any other reason, including diarrhea or vomiting or sweating, or you're just not drinking enough, that can cause the sodium level to go high. A condition called diabetes insipidus, which essentially causes you to lose an inappropriate amount of water, that can also cause the sodium level to go high. Symptoms can include things like incredible thirst, confusion, or even seizures if it's severe. Low sodium levels, also called hyponatremia. Different causes, again, medications. You can see a theme here. Changes in how much water you're taking in, as well as vomiting, diarrhea, poor nutrition. If you're inappropriately retaining a lot of water, whether due to hormone imbalances, that can be seen in a lot of different conditions that we call SIADH, or syndrome of inappropriate antidiuretic hormone, essentially causes you to retain an abnormal amount of water. Symptoms, again, very similar: weakness, confusion, and seizures. And again, similar to abnormal potassium levels, the treatment of abnormal sodium levels also depends on the cause and the severity. Now, moving on from the kidneys to the other major organ that we definitely pay attention to closely, liver function tests. Now, on a CMP, or separate hepatic function panel, we do check liver function tests. There's liver transaminases, as I mentioned, the AST and ALT. And then there's more gallbladder and biliary or bile duct system related tests as well that often go hand in hand with the liver, including alkaline phosphatase. We often shorten the term to ALK-Phos, or bilirubin, or Bili. Only the total bilirubin is typically reported on a CMP, but this can be separated out into direct and indirect bilirubin. And I'll go into what those exactly mean later. Other liver enzymes that we don't typically check include LDH and GGT. Again, similar to having a low creatinine, having low LFTs below the lower limit of normal reported on your lab's reference range, typically not a significant concern to us. Now, the two main liver enzymes, AST and ALT, many different things, again, can cause mild to moderate elevation in the transaminases. And you can see in this list here different things that can cause mild to moderate elevation in like the hundreds range. And the AST can also be high in non-liver related conditions, along with the ALT as well. But the AST can also be high in things like a heart attack or muscle injury, because it's not just a liver-specific enzyme that we're seeing. There are more classical things that can cause severe increase in the transaminases to the level in the thousands. Very commonly, things like overdosing on Tylenol, or an acute hepatitis infection of any of the hepatitis viruses, too much alcohol intake, or sometimes autoimmune disorders that can cause inflammation in the liver, or ischemic hepatitis, which is where you have a sudden lack of blood flow. Say a person is critically ill and they have very low blood pressure from infection or issues with their heart, and they have a lack of blood flow to the liver for a period of time. It can cause what we call ischemic injury. And then many other toxins and medications, including, of course, chemo and immunotherapy, we can very commonly see all severity levels of elevations in the enzymes. Alkaline phosphatase and bilirubin can be high due to liver, gallbladder, or other issues as well. So ALK-Phos, it can be high due to liver or bone issues primarily. And there is a way to separate out the ALK-Phos to see, is it looking more like a bone-related issue versus a liver-related issue? And that does require a separate test, but it does help us figure out what type of further testing we should get beyond just the initial ALK-Phos test. Bilirubin is a normal part of bile and blood. There's two main types that I mentioned. There's unconjugated or indirect bilirubin. This is when the bilirubin is bound to albumin and circulating in the blood. Conjugated or direct bilirubin is when the bilirubin has changed into a form that your body can get rid of, and it typically goes from your liver to your small intestines primarily. And the most common causes of an abnormal ALK-Phos, choledocholitis, which really just means a gallstone that has blocked the main common bile duct, that can cause a significant elevation in ALK-Phos. Other causes of bile duct obstruction, say if any surrounding structure presses on the outside of that duct and again blocks it off, that again can cause elevation. Other things include medications, of course. Medications can cause most things. Biliary strictures in rarer conditions like primary sclerosing cholangitis, very rare parasitic type infections, and many other causes. Again, many different causes. You can see a theme here of abnormal bilirubin, and this also depends on the type of bilirubin that's high. So if we see what we call an indirect hyperbilirubinemia, meaning the indirect bilirubin is high, we often look for common things like abnormal breakup of red blood cells, a process that we call hemolysis, versus if we see more a direct bilirubin increase, then we look for any gallstone issues. Other common things that we often see in people that have no symptoms or issues at all include Gilbert's disease or other genetic disorders that affect how bilirubin is processed. Now moving on to my personal favorite topic of blood counts. There are really three main types of blood counts that we look at on the test CBC, or complete blood count. There's white blood cells, red blood cells, and platelet counts. For white blood cells, they're part of the immune system. And we always typically check a CBC with diff, meaning with a differential, where we can actually count the different types of white blood cells that we're seeing in your blood. Red blood cells help carry oxygen throughout the body, and platelets help to form blood clots to help us to stop bleeding. Now, here's just a sample report that lists all of the common reported elements on a CBC with diff. There's the white blood cells, where you can see the total white blood cell count at the top. And then we see the differential part where it lists the counts for all the types of white blood cells, including the neutrophils, lymphocytes, monocytes, etc. And then there's the red blood cell components, where we typically measure red blood cells primarily by hemoglobin and hematocrit that are reported. And then there's associated characteristics, including the MCV, or mean corpuscular volume. There's MCH, MCHC, RDW, that tells us about the shape, size, and color of the red blood cells. And that can often give us a sense of different bodily processes that are going on. And then there's the platelet count, which is pretty straightforward. So starting off with red blood cells, when a person has too few red blood cells or low red blood cell counts, that's called anemia. And per the World Health Organization, defines anemia as a hemoglobin of less than 12 in women or less than 14 in men, although you can see different reference ranges in different labs. And then other anemia parameters that I was mentioning, there's MCV, which refers to the size of red blood cells. And then there's the MCHC, which refers to essentially the coloration of the red blood cells, how pale or dark they are. And then there's the RDW, which tells us about the range in size of the different red blood cells that we're seeing. And as I mentioned, size, shape, color can tell us a lot about an anemia and the most common causes that we should look for first for that type of anemia. And if we see any abnormal blood counts on your blood work, again, similar to creatinine, we always like to trend it. How new is this, or how long has it been going on for? Because that can also give us a sense as to what could be going on. Common causes of anemia include things like low iron, low B12 or folic acid levels. Of course, any blood loss can cause anemia. Chronic kidney disease, so the kidneys produce a hormone called erythropoietin, or EPO, that helps our body to make red blood cells. Chronic inflammation or any type of critical illness can actually suppress the bone marrow where our blood cells are made, and so that can cause low blood counts. Genetic disorders like sickle cell or thalassemia causes a chronic anemia since, from the time of birth. And then, of course, different blood-related cancers or disorders like leukemias and lymphomas can cause low blood counts. Symptoms of anemia, they can be quite vast, but more common and general symptoms include significant fatigue. You can have chest pain if it's affecting blood flow to the heart. You can have shortness of breath, lightheadedness, dizziness. So a lot of different symptoms we look out for. Just a little advisory for iron deficiency anemia. So if we do diagnose someone with iron deficiency anemia for the first time and you don't have any clear reason for your iron deficiency anemia, we very commonly recommend an updated evaluation with a gastroenterologist to consider an endoscopic evaluation with a colonoscopy and or an upper endoscopy, depending on your history, to see if there are any signs of potential blood loss in the GI tract, because the GI tract is one of the most common sites for what we call occult blood loss or slow blood loss without a person realizing. And this can be due to anything from benign causes like ulcers or diverticulosis or hemorrhoids to, of course, cancer-related causes. It's also common within the world of kidney, bladder cancer, et cetera, to have iron deficiency anemia, especially if you're having chronic blood loss in your urine. So anywhere up to 60% of patients with bladder cancer, for example, will have iron deficiency anemia until they're fully treated. If you have too many red blood cells, that's a condition that we call polycythemia, or more specifically erythrocytosis. And that's defined as a hemoglobin greater than 16.5 in men or greater than 16 in women, or also the listed hematocrit levels as well. And again, we trend the counts to see, is this looking more like a primary chronic blood-related disorder versus a secondary polycythemia in response to something else. Causes of primary polycythemia, the most common one that we typically talk about is due to a genetic mutation in your bone marrow and blood that causes a bone marrow cancer or disorder called polycythemia vera or PV, or a similar other classes of bone marrow cancers called myeloproliferative neoplasm. And so we can check for one of the most common mutations called JAK2 V617F, and that can actually be checked just on regular blood work as well. If we encounter significant polycythemia for the first time in a person with no clear cause. Causes of secondary polycythemia, meaning the blood counts are going high in response to something else. Chronic hypoxia, or the body sensing chronically low oxygen levels, very commonly increases red blood cells because your body's trying to compensate for sensing that lack of oxygen by increasing the amount of red blood cells it makes to carry more oxygen to other parts of the body. And this is commonly seen in people with chronic lung or heart diseases, as well as people with sleep apnea, especially if they're not on a CPAP regularly. We see it in smokers, so a lot of different conditions. We can also see this if people are significantly dehydrated, so all the blood counts become more concentrated and look higher than normal. Also, in rare instances, we can see tumors that actually produce EPO, that hormone that helps us to make red blood cells. Some tumors in a paraneoplastic syndrome can actually make that hormone itself and cause the red blood cells to go high, especially in kidney cancers. And then different medications. People who are on testosterone supplementation, or if they're on EPO injections, that can also cause red blood cells to go high. For platelets, too few platelets refers to a condition called thrombocytopenia, and that's usually when the platelet count is below 150. Common causes, medications, many different medications can cause low platelet counts, chronic liver and spleen issues. So the liver makes a hormone called thrombopoietin that helps us to make platelet counts, similar to how the kidneys make EPO to help us make red blood cells. So anyone with chronic liver diseases like cirrhosis can have low platelet counts because of that lack of thrombopoietin production. People with chronic viral infections from HIV to hepatitis B and C, it can very commonly cause low platelet counts. Many different autoimmune disorders, but most commonly we talk about immune thrombocytopenia, or ITP, can cause low platelet counts. Low B12 and folic acid levels. So B12 and folate help us to make our blood counts as well. So again, we can see low platelet count if a person's low in these. And again, as I mentioned before, any type of critical illness or significant inflammation in the body can suppress the bone marrow, leading to low platelet counts along with other low blood counts. And then any type of primary bone marrow disorder can also potentially cause low platelet counts as well. Having too many platelets or thrombocytosis, meaning a platelet usually greater than 450,000, that's sustained. Common causes, actually iron deficiency can cause a reactive increase in platelets as well as white blood cells. Also inflammation can cause a reactive increase in platelets and white blood cells. And also primary blood and bone marrow disorders or cancers. Most commonly we talk about essential thrombocythemia. And again, one of the most common initial mutations that we check for a high platelet count where we're suspecting a primary bone marrow disorder is actually the same JAK2 that I had mentioned earlier. And then there's other common mutations that we can see as well with high platelet counts and that bone marrow disorder. Now moving on to white blood cells. Now these are the main types of white blood cells that we see reported on a blood count differential. There's the neutrophils, which help us to really fight infections, including bacterial, fungal, and viral infections. There's monocytes, which essentially help us to clean up damaged cells. There's eosinophils, most classically involved in allergic type responses, but also in parasitic infections and other conditions. There's lymphocytes, which are working in our immune system to help us make antibodies. And then there's basophils, which also help with our allergic response. So again, going back to this blood count with differential, we see the reports here. And usually the absolute number of the types of white blood cells are a lot more important to us than just the total white blood cell count. So often we can see a person with just a slightly low white blood cell count, but all of the different types of white blood cells are actually normal. And that's actually just their normal baseline and not of any clinical significance. For white blood cells, having too many white blood cells is called leukocytosis. And we always pay, again, more attention to the type of white blood cell that's high and not just the total white blood cell count. With neutrophils, if neutrophils are high, we call that neutrophilia. Secondary causes include infection, inflammation. Steroids can very commonly cause the neutrophil count to go high. Any acute illness, I mentioned iron deficiency, different cancers can cause the neutrophil count to go high, smoking, and there's of course primary causes that are relatively less common, including chronic myeloid leukemia, and then some of the other bone marrow disorders that I've already mentioned. And then low neutrophil count, or what we call neutropenia. Again, common causes include medications, infections, critical illness, autoimmune disorders can also cause the neutrophil count to go low. And primary causes include myelodysplastic syndrome, which is a bone marrow cancer, and also aplastic anemia, which is also a bone marrow related disease. For lymphocytes, if you have a high lymphocyte count, that's called lymphocytosis. Secondary causes, so reactive increase to other bodily processes include viral infections, medications. We can see it go temporarily high, say after a vaccination. Primary causes, one of the most common causes for a primary blood disorder or leukemia, especially as we get older, is chronic lymphocytic leukemia, or other lymphoproliferative disorders can also show up as lymphocytosis. And a lot of people end up having it picked up on just regular screening blood work with no other associated symptoms, and we can often just watch. If the lymphocyte count is low, that's called lymphopenia. And again, secondary causes usually chronic viral infections can cause it to go low, medications, people with immunodeficiencies can have lymphopenia, and also malnutrition. For eosinophils, if you have a high eosinophil count, that's called eosinophilia. If it's reacting to something, most commonly it's due to allergic reactions, inflammation, or parasitic infections, as I mentioned. Other primary causes, relatively rare, primary bone marrow disorders or hypereosinophilic syndrome. A low eosinophil count, typically not a clinically significant issue that we encounter. For monocytes, if you have high monocyte count, that's monocytosis. Again, many similar causes, including inflammation, infection, autoimmune disorders. Primary causes can include things like chronic myelomonocytic leukemia or CMML, CML meaning chronic myeloid leukemia, or acute myeloid leukemia as well. If you have a low monocyte count, that can be due to different medications, if your immune system is suppressed, critical illness, etc. And then for basophils, if you have a high basophil count, that's called basophilia. That can be in reaction to any type of inflammation or allergic type response. Also hypothyroidism can cause it, as well as some infections. Primary causes, again, bone marrow disorders within the class of myeloproliferative neoplasms. And then a low basophil count, also typically not a clinically significant issue. Now, just a few real world patients that I've seen to kind of help tie all of this together. So I had Mr. L. He's a gentleman in his early 80s in his normal state of health, and he went to his primary care provider and had some basic screening blood work with a CBC with diff and CMP. On his CMP, we saw that he had abnormally elevated liver enzymes, but especially the ALK-Phos was in the 2000s. Usually normal is in the low 100s. And then he had some chronic kidney disease with a creatinine of 1.4. So he had abdominal imaging as well as bone imaging to try to tease out, was the ALK-Phos more related to liver or bone issues? And he was actually found to have bone lesions. And then he was sent to me for a consultation due to concern for cancer. We checked a PSA test or prostate cancer screening test. It ended up coming back quite high at 107, normal being less than 4. And we ended up diagnosing him with metastatic prostate cancer, which he's on treatment now, doing very, very well. And men can still live for years with newly diagnosed metastatic prostate cancer. Now, Ms. W., a woman in her late 60s who was initially referred to me for very early stage non-invasive breast cancer that we call DCIS, or ductal carcinoma in situ. She had already gone through surgery. She was set up to start radiation, and she was seeing me to start on anastrozole, which is an anti-estrogen pill to help reduce the risk of further breast cancer coming back. I got screening blood work on her, and I ended up finding an anemia to a hemoglobin of 10.3. And also she had an elevated creatinine to 2.2. Again, normal creatinine being down in the low 1 range typically, and a hemoglobin normal for women usually above 12.0. And I did further workup of that anemia, as well as looking into causes of her kidney dysfunction, because she didn't have any clear risk factors like a long history of high blood pressure or diabetes. And we ended up diagnosing her, unfortunately, with a second cancer called multiple myeloma, which is a bone marrow-related cancer of the plasma cells. She's doing very, very well, and she's also currently on treatment. Ms. S., she's a woman in her early 50s. She had a remote history of Hodgkin lymphoma 20 years ago that was very much cured with chemo and radiation at that time. She was seen for a regular checkup just as part of her survivorship screening, and she had screening labs done that ended up finding an anemia to a hemoglobin of 10.6. And then we did further initial workup of that anemia and ended up finding low iron levels with a low transferrin saturation of 8%, goal usually being above 20%. And a ferritin low normal at 47. We usually like it above 100 if possible. And she unfortunately ended up getting diagnosed with a colon cancer because she had an updated GI evaluation. She was also diagnosed at the same time with a uterine cancer because some of her biopsy findings on her colonoscopy was suggestive of a genetic syndrome called Lynch syndrome, which we then confirmed on genetic testing. And so she had both removal of her colon cancer as well as her uterus and ovaries all at the same time. And she's actually doing very, very well. She's essentially cured from her cancer now, and her teenage son is also aware of Lynch syndrome and can start cancer screenings earlier. All right, so now that I've covered all of that information, I'll turn it over to you all. I hope that you found this helpful in some way to help give a better understanding, or at least more information on the most common types of labs that we check and how you can use that information in the future. Please feel free to ask any questions.
Awesome. Thank you so much, Dr. Phuoc. We do have a few questions, and if anyone else had some questions come up, feel free to type them into the chat box. First question we had was from Peggy Zuckerman, who just happens to be a kidney cancer survivor, and she is going to be our next speaker in January. So, but she's got a question on, would the presence of a tumor affect the BUN or other measures? And what if there is just one kidney? How does that change measures?
And those are great questions. So especially if you have tumor involvement affecting the kidney function in any way, often we can pick that up on the blood tests, and you can have abnormal elevation in the BUN and creatinine, as you mentioned. If it is affecting your kidney function, very often people with kidney tumors, if they can still have normal kidney function, so we can still see normal levels, but we can also see abnormal levels too. So we try to get a sense of where your baseline is currently and how it's trended over time if you've had blood work before. Now, you brought up the question of what if you only have one kidney, and that's a great question. Very often we always get concerned about kidney function in people that need removal of a kidney, or if they need chemo and then say removal of their bladder, et cetera. And we always want to know a baseline, and that'll help us give a sense of their risk of how bad could their kidney function get if we expose them to the typical standard chemo that we like to give, say for bladder cancer, or if we remove one of their kidneys for, say, a single isolated tumor, how much could their kidney function potentially go down? And should we potentially consider just a partial removal of the kidney to help preserve some kidney function, or more relative than taking the whole kidney out? So great questions.
And Glenn, it's not much of a question, more of an observation, but maybe you have some comments on it. I noticed that as of October 28th, the EGFR reporting on my labs changed. In my case, it went from a general reporting of saying higher than 60 to a specific number.
Yeah, also a great question, and one that we definitely encounter a lot in clinical practice. So that depends on each lab and exactly what assay that they use or what company they partner with for all the different materials that they need to actually do their lab tests. So often it'll change from one reported reference range to another. And often that can get concerning to patients, especially if, say, an institution has been with one company doing a certain blood test for a certain number of years, and then we suddenly change the type of material or test used and the range is slightly different, and then things start getting reported as abnormal, but it's actually just their normal baseline and how it's been all along. So it's really just more based on the exact test that the lab company is using.
And Peggy asks if these slides would happen to be available to her and other people going forward. If I know sometimes sharing the slides can be problematic, but what are your thoughts on that, Dr. Phuoc?
Yes, I'm happy to share my slides. This talk is approved by Moffitt for me to give, so I'm happy to share my slides.
Great. Then if you could just email those to me, I'll make sure that when they're posted to our website, when this video is posted to our website next week, that we include the PowerPoint as a link below.
Yep, absolutely. Can definitely do that.
And Peggy says, it seems that kidney cancer is not grouped into the kidney disease world. Kidney cancer patients will rarely see a nephrologist. And wonder if this is, and I think we're missing a part of that comment. But do you find that that's true, Dr. Phuoc?
No, that's a great observation and very much true. So, and also it kind of ties in as to how I mentioned a lot of people with kidney cancer can actually have normal kidney function to start out with. And people that deal a lot with kidney cancer are usually very accustomed to monitoring kidney function and trying to optimize things as best they can from a cancer perspective. But a lot of the times, once you've had your initial treatment, or if you have other issues contributing to your kidney function, especially things like blood pressure, diabetes, we very often also need to work with your primary care provider or with a nephrologist to have more advanced skills to help optimize your kidney function. But it is a great observation that we can definitely do more and be better about trying to have more comprehensive care for people with kidney cancer.
Awesome. Well, I want to thank you for your time today, Dr. Phuoc. If anyone missed any part of this presentation, we will be providing the recording of it on our website next week, so you can check back then. And if anyone is interested in signing up for any future kidney cancer conversations, let me share my screen here and I'll pull up the page real quick. You can currently sign up for our future kidney cancer conversations from our website. And Peggy, who was in attendance today asking great questions, will be our next speaker on January 19th. We're really excited for that talk. And thank you so much, Dr. Phuoc, for sharing your time. We look, if we have any questions, will we be able to follow up with you in the future about that?
Yep, absolutely. Please feel free to email me if you do have any questions.
Thank you, Dr. Phuoc. And Erin says, great presentation. Thank you.
Oh, thank you so much for having me.
Y'all have a happy holidays. I'll see you at the turn of the next year. And I look forward to having you on our next kidney cancer conversation. Have a great day, everyone.
Happy holidays.